Hi, good evening. Good evening, everyone. I'm Dr. Gurav Patel, and I am surgery faculty at DAMS. So today in this Medskool session, I guess the audio and screen is visible. Okay, so in this session, we'll be discussing 1 hour about the thoracic trauma. Okay, so thoracic trauma will be our topic for today. All the important aspects, the important things about thoracic trauma which they ask in the different exams like Neet PG, INICET and FMGE. So we'll be discussing these things. Hey, good evening everyone. Okay, so in this thoracic trauma, the first injury we'll discuss is hemothorax. Okay, as you see the name hemothorax suggests blood in the pleural cavity. Okay, so this is like blood in the pleural space. This is hemothorax. Like in this side, there is accumulation of blood between the two layers of the pleura. One layer which is along with the lung, and the another layer which is present on the chest wall. So between these two, if there is blood present, that is hemothorax. Now this blood, if it is more than 1500 ml, or in pediatric age group more than 20% of the total blood, then this is known as massive hemothorax. Okay, this is massive hemothorax. Okay, so a very common injury mostly occurs because of the blunt trauma to the chest. It can occur because of the blunt trauma, because of the penetrating trauma. Clinically, if we see, the patients will have a problem in, there will be dyspnea, tachypnea. Then on examination, if you on inspection, there will be decreased chest movement. Then there will be decreased breath sounds. And a very important thing, how in the exam you will know that they are talking about hemothorax. When you do the percussion, on percussion there will be dull note. Dull note on percussion will tell you that they are talking about hemothorax. Okay, so this is the first slide. Okay, Jaipuriya, so don't worry about it. So with these clinical features, patient comes with a history of either blunt trauma or penetrating trauma. On investigation, if you get the chest x-ray done, you can see on this side, this right side appears normal. This side, this blunting and this accumulation of the fluid, this is suggestive of hemothorax. Sometimes when there is massive hemothorax, like you can see on this side, there is complete whiteout. Complete whiteout can be seen, and if there is blunting of the costophrenic angle. So these are the things you will see on the chest x-ray. But these days, because chest x-ray takes time, and in trauma, our main race is against time. So any investigation, any treatment which can be done early will be the better investigation and the better treatment. So these days we go for extended FAST. Okay, I'm sure you all know that FAST is a type of ultrasound, that is focused assessment sonography in trauma. Okay, so this is the ultrasound which is done by the surgeons, and we put the ultrasound probe at the specific areas to see the injuries in the abdomen. Now at the same time, if you want to assess the injuries of the thorax, you do this extended FAST, in which you put the ultrasound probe on the right and left side also. Like you can see on the right side, this is the lung, this is the liver. Okay, so this accumulation of fluid. Okay, this fluid, in case of trauma, we consider this fluid as blood. Okay, so this is on the right side. On the left side, you can see between spleen and the lung, this accumulation of blood, this is hemothorax. Okay, so on the E-FAST, these are the features of hemothorax. There is accumulation of blood in the pleural cavity. The source of the blood is mostly the intercostal vessels. Okay, mostly the intercostal vessels which are running just under the the rib. They are the source of injury. It can be from lung also. From lung also, lung is supplied by both pulmonary and bronchial artery. That can also be the source. How can we differentiate between hemothorax and what? If you are asking radiologically, you cannot differentiate between a hemothorax and the pleural effusion. For that, you need to see the question. Okay, if there is something chronic, some history of tuberculosis and chronic history, then consider it as pleural effusion. Some malignancy, consider it as pleural effusion. If there is history of trauma, consider this as hemothorax. Okay, radiologic on basis of X-ray or on the basis of EFAST, you cannot differentiate. You cannot tell what is the character of this fluid. It can be a pleural effusion. It can be the abscess. It can be blood also. But if it is trauma, we consider it as blood. Okay, now see, there is bleeding, but 95% of the bleeding, it will stop spontaneously. It will stop on its own. You should not be worried about the bleeding part per se. Okay, you should not be worried about the bleeding part. The main problem is that suppose this is the lung. Your main problem is because of the accumulation of blood in the pleural cavity. Now this side lung is not getting the space to expand. Okay, so that's why the treatment is on this side under the local anesthesia on the bedside only. You put a tube where one end of the tube is inside the pleural cavity, the another end of the tube is in a container which has little bit of 100 ml of saline already filled in this. Okay, so this tube is known as intercostal chest drainage tube. Now the moment you will put the tube, this blood will start coming from this tube and it will start accumulating in this container. You can measure how much blood has come immediately, and then after every hour how much blood is coming through this. Okay, like I said, bleeding will stop spontaneously. All you need to worry is that you give some space for the lung to expand, and the patients, they recover like magically. The moment you put the ICD, they feel so much of relief and everything. Okay, so yes, pneumothorax you can differentiate clinically. Meet Patel. We'll discuss the next injuries pneumothorax only. I'll tell you how to differentiate hemo and pneumothorax clinically. Now, aspiration is absolutely out of the question. Okay, aspiration is out of the question because you cannot keep on, you cannot ask the patient to sit there and you put the needle and you keep on aspirating there. Okay, because if it is for pleural effusion, you can do aspiration mainly for the diagnostic purpose. If you want to send it for whether it is exudate or transudate, for that thing aspiration is fine. But for the trauma, ICD is the answer. Okay, no aspiration. Don't try to do aspiration in traumatic patients. Now the problem, important thing about this question is about this ICD is, first of all, what is the size of the ICD you will put? Size these days 28 to 32 French. This you have to put. Site. Site is usually 4th or 5th intercostal space. You can say just anterior to mid-axillary line. Or even if they write mid-axillary line, that is also fine. Okay, 4th or 5th intercostal space, just anterior to mid-axillary line, that is a very safe area. You can see, suppose this is the 4th rib and this is the 5th rib. Okay, so this is the 4th intercostal space, or so let's take it 5 and 6. So this is the 5th intercostal space. Now in this 5th intercostal space, when you are putting the ICD, when you are doing the dissection, make sure you are doing dissection just above the the lower rib. You should not go in this area. Okay, this area you should not go, because this is the area where the neurovascular structures, that is intercostal nerves and the vessels, are running. So if you try to do dissection in this area, you might cause more injury. So that's why this is the correct site in the intercostal space. You have to be close to the lower rib, not close to the upper rib. Most common neoplasm of the salivary gland, if it is benign, it is hemangioma. If it is malignant, it is mucoepidermoid carcinoma. Bidesh Burman, let's focus on the trauma. Okay, so this is the site. Sometimes they ask, not this, suppose this specific thing is not given, then there is a safe area which is known as triangle of safety. Okay, so you can put the ICD in this triangle of safety, which is bounded by the lateral border of pectoralis major, the anterior border of latissimus dorsi, and a horizontal line at the level of nipple or the fifth intercostal space. So this triangle is known as triangle of safety. Okay, so that is the safe area. If you go above this, then there are chances of the injuries of the axillary vessels and nerve. If you go below this, then there are chances of injury to the liver on the right side and spleen on the left side. So this is the safe area. So the proper site is this. Suppose it is not in the option, then triangle of safety would be the would be there in the options. So this is the main treatment. Okay, you can see this is the site, fifth intercostal space, just anterior to the mid axillary line. Okay, so you'll put the tube, and one end of the tube is inside the thorax, the other end of the tube is inside this, the intercostal, this collecting bag, underwater seal we call it as, so that you know how much amount of blood is coming out from this tube. So treatment, we have seen that mostly the treatment is via ICD. Now what is the indication for surgery? Surgery means thoracotomy. Okay, putting the ICD is just a procedure that you can do bedside. Surgery is you need to shift to the patient to the OT, you need to open up the thorax and go inside and see the thing. And thoracotomy, which we do for the trauma patient, is anterolateral thoracotomy. Okay, anterolateral thoracotomy, where you will give incision just lateral to the sternum and go up to the mid axillary or sometime posterior axillary line. Posterior lateral is you start from the mid axillary and go up to the the posterior up to the vertebra you go. So that is posterior lateral thoracotomy. For trauma, for lungs, mostly we go for anterolateral thoracotomy on whatever side it is. Okay, so when to go for surgery? Two main indications I want you to remember. Anterior to mid axillary means just anterior to the mid axillary line. Suppose this is the mid axillary line, so you have to go just anterior to that. Many times they just write mid axillary, that is also fine. Okay, that is also fine, but ATLS says just anterior. Even if they write mid axillary, that is also okay. Okay, so like I said, mostly when the patient comes, you make the diagnosis of hemothorax, you put the ICD. Suppose the moment you put the ICD, more than 1500 ml blood comes from the ICD and it gets accumulated in that container or the underwater seal. It means there is massive hemothorax. More than 1500 ml of blood comes out initially. Or you can say the moment you put the ICD, more than 1500 ml blood comes. It is an indication that it is a massive hemothorax and you might have to open up the patient and control the bleeding. Second indication is, suppose the blood which has come is not 1500, it has suppose 800 ml, 600 ml. Then you have to see how much blood is coming from that ICD every hour. And if it is more than 200 ml per hour output from ICD for 2 to 4 consecutive hours. So I want you to remember these two indications for surgery. Okay, let's take this suppose as example. There is a patient A. The patient A comes, you put ICD at 7 p.m. So the moment you put ICD, 1600 ml blood comes immediately. Okay, you have to go for surgery. Suppose there is patient B. The moment you put ICD at suppose 7 p.m., 800 ml blood comes. 800. It is okay. At this moment, you are not supposed to go for surgery. Now, from 7 to 8 p.m., if it is 220 ml, 8 to 9 p.m., 210. Now also you can go for, because there is 2 consecutive hours, more than 200 ml, you can go for surgery. But suppose you want to wait, so you can wait 9 to 10 p.m., 205 ml, 10 to 11, 210 ml. So it is now 4 consecutive hours you have to open up the patient. Every hour the output is more than 200 ml. So you have to see minimum 2 hours, maximum 4 hours, and if it is more than 200 ml, it means there is some ongoing bleed, and unless you open up the patient and control the bleeding is not going to stop on its own. Okay, so this is about hemothorax. This injury is hemothorax, and we have also discussed a little bit about the ICD, where it should be placed. Next injury, like you said, how to differentiate it from pneumothorax. Pneumothorax. Okay, pneumothorax is there is accumulation of air in the pleural cavity. Air. So from where does the air comes? You can see what is the source of air. Air can come from outside, because in the thorax there is negative pressure. So if there is any opening, it will try to take the air from outside. In abdomen there is positive pressure. So if there is an opening, the intestine, the abdominal content will try to go out. But in thorax, because of negative pressure, it will take in the outside thing. Okay, so either it can come from out, and a very major source of air is lung. So from lung also it can go, and ultimately the air will accumulate in the pleural cavity, causing it to be a pneumothorax. And that air will push the ipsilateral lung, so the lung will not get a space to expand, and that is the main problem in pneumothorax. So clinically, how to differentiate? There will be, same as hemothorax, dyspnea, tachypnea, decrease chest movement and breath sounds. But what is the main differentiating factor from the hemothorax? Because these things are seen in hemothorax also. Pneumothorax, when you do the percussion, you will see the hyperresonant or tympanic note. Okay, and in hemothorax you have seen, you see the dull note. Normal note of the the thorax is resonant. It is hyperresonant or tympanic in pneumothorax. It is dull in hemothorax. Yes, very good, Swati Roy. It is a hyperresonant note. So this is pneumothorax. On chest X-ray. Okay, this is the chest X-ray. Although these days chest X-ray is not our preferred investigation modality if you are suspecting pneumothorax, but still, if somebody gets a chest X-ray done, you can see this is the normal lung, because in the normal lung you will see it's not jet black. Okay, there you will see bronchovascular marking. It is kind of grayish with some white lines are going here and there. On this side you can see this. Okay, this line. This is the lung. Rest, this jet black thing, this whole thing is air. This whole thing is air. Okay, so this is what you see. I can draw that lung boundary for you. This is the lung boundary, which is compressed, and it is not getting a space to expand because the space is taken up by the air in the pleural cavity. Okay, so this is the X-ray. This is the visceral pleura. Like I said, X-ray, because X-ray takes time, so these days again the ultrasound, E-fast, is becoming very popular, and in fact you can say this is the better investigation modality because you get the results immediately. So E-fast, we have seen what you will see on hemothorax. There will be blood between the lung and the liver on the right side and spleen on the left side. Okay, there will be blood, there will be fluid. But in this case there is no fluid, so you will not get that image. What you will see here, there is something known as seashore sign. Seashore sign is for normal lung. Normal lung. And in pneumothorax you will see barcode or stratosphere sign. So barcode or stratosphere sign is what you will see in pneumothorax is what you will see on pneumothorax. Okay, now how will you differentiate these two? Let me tell you, just imagine this, dot dot dot, it's like a sand. So just imagine it as a beach. This is a beach, suppose. These are the ocean waves. And suppose this black color thing is sky. Okay, so there is beach, there is ocean, the waves of the ocean, and there is sky. And in pneumothorax, just remember like that, because pneumothorax is a serious condition. So it's like a tsunami which has come in the patient's body. So what happens in tsunami? The whole ocean comes on the beach is washed away. This is what you can see in the barcode stratosphere. There is ocean only. No beach. Beach is washed away by the ocean. So you can remember it like that. So it helps in exam to differentiate whether it is a seashore sign or a barcode sign. If you don't see that dot dot beach kind of appearance, it is barcode or stratosphere sign. If the EFAST is not available and clinically it is like a pneumothorax, then you can go ahead, you can go for the, if the patient is stable enough to wait for the X-ray, go for that. Otherwise, you can straight away, based on your clinical judgment also, you can put the ICD. Okay, that depends on the patient condition and that depends on obviously the judgment of the doctor as well. Now, see, pneumothorax is different types and the management is also different. You need to understand this. This is very important point. There is a type of, first we'll see, there is a simple or closed pneumothorax. Simple or closed. Let me show you here. Suppose in simple or closed, the air is going into the pleural cavity from the lung, but some amount of air is going back also. Okay, so there is bidirectional flow of air. There is accumulation of air in the pleural cavity, but the air is going in both the direction. It is coming into the pleural cavity, it is going out of the pleural cavity also. So in this case, the patients are generally not very sick. So that's why the treatment in this case is, if the patient is having respiratory distress, means there is some breathing difficulty and all, then you can simply put a ICD. And suppose patient has no respiratory distress, then you can wait and watch. Many times the little bit amount of air gets reabsorbed on its own, so you don't have to do anything as such for a simple or closed type. If there is respiratory distress, you put the ICD. And remember, no matter what is the diagnosis, if you are putting the ICD will always go in that 4th or 5th intercostal space in the mid-axillary line. Whether it is pneumothorax or hemothorax or whatever thorax, ICD space is, the site of ICD remains same. Only thing is, because this is pneumothorax, so you can take the smaller size. You can take maybe 28 French, 24 French. So you don't have to take the 32 French ICD because that is mainly for the blood. For the air, you can take the smaller size. Second one is more dangerous, that is open pneumothorax. So now just focus. In open pneumothorax, there is a open wound on the chest wall. Like you can see, there is a open wound on the chest wall. There is some penetrating injury, some shotgun kind of injury. So there is a open wound on the chest wall, and if that wound is more than 2.5 centimeter, just listen. What happens? I told you that normally in the thorax there is negative pressure, and because of the negative pressure, the lungs, they expand. Now because of this opening, the outside pressure, that is the atmospheric pressure, and the intrathoracic pressure becomes same. By same, I mean almost same. It means there is loss of negative pressure inside. And if there is loss of negative pressure, the lung will not expand. Lung won't expand. And if the lungs are not expanding, there is accumulation of air. It cannot push the air out, although there is an opening there through which the air can go out, but that will go out only if the lung will expand, and it is not expanding because there is loss of negative pressure. So this is a kind of emergency. This is much more dangerous as compared to a simple pneumothorax. Okay, so that's why in these cases the immediate management, the moment you see the patient, what you are supposed to do is this open wound, you cover the wound from 3 sides. Okay, so that is 3-sided occlusive dressing, like which has been shown in this image. You can see 3-sided. One side you keep it open, and after doing this, the moment you will do this, now again the negative pressure will start building, the lung will expand, and this side you kept it open. You can see this one side you kept it open, so that now when the lung is expanding, it can start pushing the air from this side. In the meanwhile, you will prepare your, the things for the ICD, that underwater seal and everything, and then you will put the ICD. Okay, ICD. And remember, you don't put the ICD from this injured side. Okay, don't feel that already there is a hole so why not I put the ICD from this hole. That thing you have to cover from this side. You have to put the ICD from a different area, not from the site of injury. You can go a little bit above, little bit below, little bit anterior, posterior, in the triangle of safety, anywhere you can put. Okay, so this is the treatment for open pneumothorax, which is, like I said, more dangerous as compared to a simple or closed type. Okay, so simple we have seen. What is simple? What is the treatment? Open we have seen. What is open? What is the treatment? Third type is the most dangerous one. That is tension pneumothorax. So what is the main problem in the tension pneumothorax? In the tension pneumothorax, suppose in this case the injury has occurred in such a manner that it is only coming towards the pleural cavity. The air is coming towards the pleural cavity. There is one-way flow of air. Okay, this is known as flap valve mechanism. Flap valve mechanism, like there are few doors. Okay, there are few doors which open in both the direction. Either you pull it or you push it, it will open. But these days, most of the doors, they open in one direction. Either you pull or you push. So in this case, the injury has occurred in such a manner that it is opening towards the pleural cavity only. If the air will try to go towards the lung back, the gate will close. So that's why there is one-way flow of air into the pleural cavity, and because of this, there is rapid. If there is injury at the site on the triangle of safety is the safest area. Okay, if you think that, okay, triangle of safety is a big enough area. Suppose you, as per your hypothetical Rajat situation in which there is an injury, the whole thing is gone, blown away, then if you close it from 3 sides, you can go a bit posterior, a bit anterior. I told you what is the dangerous area. Dangerous area is if you go more above, then there is axillary structure. If you go more below, then there is, liver. Okay, in your hypothetical situation, suppose this whole thing is gone, usually the patients, they don't survive in this that much big, loss of the chest wall. So, I mean, probably you will not be looking at a live person in that scenario. Okay, so rapid accumulation. So there is very rapid accumulation of the the air into the pleural cavity, and because of this rapid accumulation, can you see this rapid accumulation of the air will push the heart towards the other side. Okay, with every breathing it is pushing the heart towards the other side, so it will push the heart, and in this case the heart rotates on SVC and IVC. Already one side of this is like this is the exact Meet the exact thinking. Because of that, I told you that you have to cover that from 3 sides, because unless you cover it from 3 sides, you cannot create that seal which will produce the negative pressure. So remember, you are covering that wound to create the negative pressure. So if you try to put the ICD from that area, first of all, that area is not the sterile area that can cause injury, that can put the infection inside the thoracic cavity. And the second thing, your main purpose of maintaining the negative pressure will be lost. So that's why you don't put it from the site of injury. So heart rotates on SVC and IVC. This will cause decreased venous return, and because of decreased venous return, there will be decreased blood pressure and it will lead to hypotension. And this kind of shock in which there is some obstruction to the venous inflow to the heart, it is known as obstructive shock. So this is one of the example of obstructive shock. So how will you differentiate in the exam that whether they are talking about the simple pneumothorax or open pneumothorax or tension pneumothorax? Simple is simple. In open, they will tell you that there is an open wound, and in tension, you will differentiate tension by looking at hypotension. In the pneumothorax, if there is hypotension, means they are talking about tension pneumothorax. They don't have to write tension in that. It is tension pneumothorax. So like I said, this is the most dangerous one among the three. Okay, if we arrange the three as per the severity and the the danger, the most dangerous is tension, then comes the open, and then comes the simple. So because this is a real surgical emergency, you are not supposed to do, even like somebody said that if ultrasound is not available, don't worry about ultrasound. This is a clinical diagnosis. The first thing you will do is put a needle. Put a needle. That is known as needle thoracocentesis, because one side of the thorax has become like a balloon which is expanding, and that is pushing the heart towards the other side. The moment you put the needle, the gush of air will come out, and the mediastinal shift will stop, and you get sufficient time to arrange for the ICD and put the ICD. Now comes about this needle. What is the site of putting needle? Now the site of putting needle is different for adult and for pediatric patient. For adult, it is the same site of ICD, so you are not supposed to remember anything different. I'll say like 4th to 5th intercostal space, mid-axillary line, just anterior to mid-axillary line. For kids, it is the 2nd intercostal space. 2nd intercostal space, mid clavicular line. Okay, so the only thing different in this whole thoracic trauma is the site of needle in the pediatric age group for a tension pneumothorax is the 2nd intercostal space. Rest, like I said, ICD, no matter it is kid or adult or hemo or pneumo or whatever thorax, it is 4th to 5th intercostal space, mid-axillary line, just anterior to mid-axillary line. Okay, the needle should be generally over the sheath needle. Over the sheath means like a cannula which has the outer plastic covering and the inside metallic thing. In general, 14 gauge and at least 8 centimeter. So these are the like ATLS guidelines, at least 8 centimeter length, the diameter 14 gauge, and over the sheath needle, and then you put the ICD. Okay, so this is the treatment of pneumothorax, a very important topic for the exam. You have to differentiate, first of all, whether it is hemo or pneumo. In pneumo, whether they are talking about simple or open or tension, because the treatment and management of all the three types are different. Most dangerous one is tension. One more, the third injury in the thoracic trauma, not very difficult. Usually you get very easy question on this: flail chest. Flail chest. Flail chest is, by definition, there are two important things in this. The first important thing is the definition. Fracture of, remember, 2 or more consecutive ribs. Cardiac tamponade versus tension pneumothorax by percussion clinic. See, Jaipuria, cardiac tamponade may the breathing will be fine. Okay, this is the most important thing to differentiate whether it is tamponade or the hemo or pneumothorax, because in hemo and pneumothorax the main problem is the breathing. So if lungs are fine, then the next your focus should go on the heart. Okay, if the lungs are fine, in the exam they write that bilateral breath sounds are normal or equal, means the lungs are okay. Now you look for the heart or maybe aorta. So in that case you can easily differentiate, not a big deal. Fracture of 2 or more consecutive ribs and at least 2 fractures in each rib. Okay, like if I draw it for you, suppose this is the sternum and these are the ribs on both the side. Directly there are 2 second, third, fourth, fifth, sixth, seventh rib. So in each rib at least 2 fractures and similarly 2 or more than 2. Suppose in this example we'll take 4th, 5th and 6th. 3 ribs are fractured and in each rib fracture at least 2 sides. So what happens now that because of this, now this part has become separated from the rest of the thoracic cage. So this is known as flail segment. Now a very important and peculiar thing about flail segment is that it has paradoxical movement. So the word paradoxical means it is happening opposite of what is usually expected to happen in this case. So like in case of normally what happens when we do inspiration, okay, the lungs expand, the thoracic cage comes out, and when we do expiration it goes in. So in this case the rest of the thoracic cage at the time of inspiration is coming out, but this particular segment it is going back and the lungs are expanding. Okay, so just imagine a expanding lung and a part from the thoracic cage is coming behind. It will hit the expanding lung, and the bigger the flail segment, the bigger injury, the blunt kind of injury it will cause in the lung. And because of this paradoxical movement there will be pulmonary contusion. Pulmonary contusion means there is blunt injury to the lung. The bigger the segment, the bigger part of the lung gets involved. So that is the main problem in the flail chest or the this traumatic case flail chest. There is injury to the lung. Okay, so whenever now we know what is flail chest by definition and what is the main problem happening in the flail chest because of the paradoxical movement. It is the lungs which are ultimately are the main sufferer. Treatment of flail chest. Flail chest is again a clinical diagnosis. Mostly it is clinical. Very nicely you will see that movement of that flail segment. You can get the X-ray also done. Fast is usually not required in case of flail chest unless you are suspecting some pneumothorax or hemothorax. Fast does not have much role in flail chest. Okay, so treatment whenever you get the question on flail chest, they will always give that if there is respiratory distress or no respiratory distress. Either they will write directly respiratory distress, or they will write that the patient is having breathing problem or the CO2 is washed away. So you have to see that in the question that what additional information they have given. So if there is no respiratory distress, all you have to do is give oxygen by mask and give analgesics. Okay, because there are so many ribs and at multiple sites it is fractured, so definitely the patient is in pain, and when they have pain on the breathing they try not to expand the lung properly, and that can cause later on atelectasis, pneumonia and other things. So that's why you give analgesics. These days people they give epidural analgesia, so that that can be controlled by the patient also. I'm sure you know what is PCA, patient controlled analgesia. That is the better thing, epidural analgesia. But if the patient is having respiratory distress, so you are not supposed to do anything for the fractured ribs. The rib fracture will heal on its own. You're not supposed to do any kind of wiring or strapping or plaster or any splint, nothing. All you have to do is that injured part of the lung because of this contusion, you need to keep the alveoli of that part open. So for that you intubate the patient, endotracheal tube, and put the patient on intermittent positive pressure ventilation. In between you can give positive pressure to keep those alveoli open. Okay, so be very cautious when you answer the question on flail chest. You have to see the clinical condition of the patient. For respiratory distress, you intubate and put the patient on positive pressure ventilation. If there is no respiratory distress, then give oxygen by mask and analgesic. No wiring, no strapping. Don't try to join the fractured ribs. So this is the third condition, flail chest. Somebody just said, I guess Jaipuria said that how to differentiate from cardiac tamponade. Few things are same in cardiac tamponade and tension pneumothorax. Okay, first let me show you something. See, this is heart, and around the heart there is a layer of pericardium. Okay, so this is because at the end many cases require surgery. No, Neet Patel, I don't know whether you have seen it or you are just thinking it. We have treated n number of patients of rib fracture and we have not done any surgery for the rib fracture. Okay, rib fractures will heal on its own because you are not supposed to do any surgery. You will be doing more harm if you do the surgery rather than treating the patient conservatively. Pericardium. So what is the main problem in the cardiac tamponade? That can happen mostly because of the penetrating injury, but can occur because of the blunt injury also. So like there is the problem in the heart. There is some injury in the heart, you can see there is some injury, penetrating injury. And because of this, the blood has entered into the pericardial cavity. This is the blood which has entered into the pericardial cavity because of injury in the heart. Okay, so that is the main problem. Now if I draw it for you, suppose this is the pericardium, this is the SVC and IVC coming. So this is the injury, and because of this, like I said, the blood has entered into the pericardial cavity. You don't need massive amount of blood. They say that if there is approximately 100 ml, sometime even less, can be lethal, can cost life of the patient. Why 100 ml of blood is killing the patient? Because the main problem this blood is causing is it is putting pressure on this right side of heart. It is putting pressure on the right atrium, right ventricle. It is putting pressure on the SVC and IVC, and because of this pressure there is decreased venous return. So like I said, any pressure or obstruction which is preventing the venous blood to reach back to the heart is a type of obstructive shock. So this is another example of obstructive shock. Remember, it is not a cardiogenic shock. In cardiogenic shock, there is failure of the contractility of the heart. Okay, failure of the pumping mechanism. In this case, you give blood to the heart, heart will pump. The pumping mechanism of heart is fine. The problem is it's not getting the blood. So because of that, clinically, if you see, because all around the heart there is accumulation of the blood, so if you put the stethoscope, you will see that the sounds which are coming are muffled heart sounds. And because of this pressure on the SVC, now the blood is not coming to the heart, so there will be distended neck veins. Distended neck veins, and like I said, hypotension is very important, and in response to hypotension there will be tachycardia also. So these are the clinical features. Respiratory wise, the patient does not have problem in breathing. Okay, so somebody asked, so this is how you differentiate whether it is a cardiac tamponade or a pneumo or hemothorax. These three things, okay, you can remember it as with the mnemonic MDH. These three things are known as Beck's triad. Okay, so this is Beck's triad. Tachycardia is also a feature, but that is not a part of the triad. Investigation, you can go for a FAST, focused assessment sonography in trauma, because the first the initial probe placement in FAST is in the epigastric region to see the cardiac tamponade only. You can go for the echocardiography also, but giving the urgency of the traumatic cases, FAST is the better answer. Why distended neck veins, Nitya? Because see, this blood is going, all this venous blood is going through these veins through the SVC to the heart. And now in the heart, around the SVC and the IVC, there is pressure. So because of that pressure, the blood is not able to go back to heart. And if it is not going back, it will start, accumulating, and that will cause distended neck veins. Okay, now treatment. Again, this is a surgical emergency. You have to do something as fast or as early as possible so that at least the heart start getting the blood. Otherwise, the patient will die right in front of you in the emergency. So what you will do is, okay, I'll make the diagram again. Suppose this is the pericardium, and this is where there was injury, and now the blood has accumulated in this, and it was preventing the blood to reach back, venous blood to reach the heart. So as the immediate procedure, you will put a needle which will go into this pericardial cavity and start aspirating the blood. You can start aspirating the blood. So this is known as pericardiocentesis. Yes, very good, Bratheria. Like you can see there, this part is xiphisternum. This is the xiphisternum where the sternum ends. Just to the left of xiphisternum, you can put the needle. Ideally, this should be done under the guidance of ultrasound, but suppose ultrasound is not there, you can go blindly also. The needle should be 45 degrees towards the skin, the direction towards the left shoulder. Keep giving the negative pressure, keep proceeding. Suddenly you will feel that the blood is coming, and now you are in the correct area. You start aspirating the blood. Okay, so this is pericardiocentesis. But remember, the main problem is not this. The main problem is injury in the heart. After some time, the blood will again come. But this is the time buying procedure. Now, after doing pericardiocentesis in the emergency room, you have got the time. I mean, you always have got the time. The patient has got some time so that you can prepare the OT, and you can shift your patient to the OT, and you can repair the injury in heart. If you try to do everything in the OT itself, there are very high chances that the moment patient reaches OT, the patient would be dead. So that's why immediate life-saving procedure is pericardiocentesis. After this, shift to OT and repair the injury in heart. Okay, so this is about cardiac tamponade. This is about cardiac tamponade. Very dangerous, injury, and the patient can die in these cases. So you have to be very vigilant, and you have to do some life-saving intervention. Like in case of tension pneumothorax, putting a needle was not the definitive treatment, but putting the needle was the life-saving treatment so that the patient can survive for some time, so that you can put the ICD. Similarly, in this case, pericardiocentesis is not the definitive treatment, but this is the life-saving intervention so that you can shift the patient to the OT and do the proper surgery and repair the injury in the heart. One more injury we'll see. This was 4. So 5 thoracic trauma injuries we have discussed. The last injury is diaphragm injury. How much blood to aspirate? As much as it can come. Okay, you can put a catheter also, so that will continuously keep on draining the blood. Otherwise, you just put the needle and aspirate it the moment, keep on aspirating till you get the OT and till you open up the patient and control the injury. Diaphragm injury that can occur again because of the penetrating trauma. That is more common in penetrating as compared to the blunt injury. Very obvious. I'll just tell you the important points. It is more common on the left side as compared to right side. Right side there is liver to kind of give some protection to the diaphragm. Left side there is no such structure, so there are more chances of rupture on the left side as compared to right. A very important thing is because of the diaphragm injury, usually not a large part of the the bowel or the viscera herniates. Usually it is a small injury, and at the time of injury, mostly the trauma surgeons, they focus on the life-threatening injuries. Diaphragm injury is not life-threatening. Usually it is not life-threatening. So many times it gets missed at the initial survey. Okay, initially when the patient comes, when we do the primary survey, secondary survey. So many times because of the small injury, and because of not the urgent nature of the injury, it might get missed. So at times in the question also says that the patient had injury a month before, and now he is coming or she is coming with problem of breathing. So at times the presentation is delayed. At times there is delayed presentation initially because the doctors and even the patient also focus on the life-threatening things, and later on, maybe after the discharge, patient comes with this problem of the breathing, so the presentation is delayed. Investigation, you can see it on the X-ray, you can see it on the CT scan also, but no X-ray, CT scan, but the investigation of choice is a diagnostic laparoscopy. Okay, if you are suspecting, it is better you make a small entry, make a small opening, put the laparoscope, and you can see that usually the left side diaphragm is injured and the bowel is going towards the thoracic cavity. So many times they say that if the injury is very small, you can repair it conservatively also. This is the fourth point when coming to the treatment. First, I'll tell you what you are not supposed to do. There should be absolutely no ICD. Don't put any ICD, because when the moment you put the putting the ICD is not a under vision procedure, it is a blind procedure. Okay, you are just making a small opening and pushing the tube through that. So if you make a cut and try to push the tube, you might injure the bowel, you might injure the small intestine or the large intestine or whatever part of the abdomen has entered into the thorax, that might be injured. So absolutely no ICD. Second thing is, surgery is the only treatment. No conservative treatment. Surgery is the only treatment. You can go for either a primary repair. If the injury is small, you just do the suture repair with a non-absorbable suture. If you think that the injury is big, then you can put a mesh also, but you have to do a surgical repair. If you think that it is going to heal on its own, that is not going to happen, and you have to repair it. Okay, so these are a few of the thoracic injury topics which I have chosen. These are the important topics which they ask. Almost every year you will find some questions from these topics. So because of the important nature of the topic, I had taken this particular topic so that you should be very crystal clear and you should be well prepared for the exam. If you have any question in the thoracic trauma, please feel free to ask. Okay, any question related to these topics? Okay, you're most welcome. How to manage these different injuries, and thoracic trauma is quite a common injury. If you work in the surgical emergencies and in the trauma centers, you will see that these injuries are very, very common, going from the hemothorax to the pneumothorax, the frail chest, okay, tamponade, diaphragm injury. Okay, so yes, definitely the next time, if you have anything in your mind, so you just let me know, so that the next topic, maybe I'll take that. I mean, any suggestion from your side is most welcome, and try to take this 1 hour class on that. Anything which you think is kind of confusing, and which is also coming as quite frequently in the exam, so I'll take that topic in the next. Okay, so thank you very much. Please subscribe to our YouTube channel and follow us on Telegram, Instagram, and we keep on putting important updates and different MCQs and different announcements, the notification, everything you will get as the first the moment it comes in the the newspaper, before it comes in fact in the newspaper and the sites, and we try to tell you all the important updates and everything, and the questions, important things. So urology, Rajat, is not a I mean, it's not a topic. It's the whole it's the whole a part of the surgery, which itself, like, it's a 10-12 hour thing. So anything particular in urology, this session will be for like 50 minutes, maximum 60 minutes. So anything which can be covered in this 50-60 minutes. Okay, if urology I just write the topics also, it will take around 45 minutes for just me to write the name of the topic. Okay, so what part of the urology, you let me know, and I'll be more than happy to take that part. I mean, if you want to discuss, if you want me to discuss, suppose testicular tumors, or maybe the renal stone, or the renal tumor, or something like that, prostate cancer, BPH. So that is a topic which can be discussed in this part. The whole urology, I'm sure you also know that it's not possible. ICD insertion in diaphragmatic injury after repair? No, because most of the time what we do when we go for the diaphragmatic injury, we go from the abdomen side. So suppose you are doing the repair, the moment you take your final bite, suppose there is just one opening, you tell the anesthetist to inflate the lung completely. So when they inflate the lung completely, all that air is drained, and now you take your final bite, the patient will be fine. Okay, so you are not supposed to put an ICD if you are doing a laparotomy for that. If you are doing a thoracotomy for diaphragm repair or for anything, when you do a thoracotomy, you put the ICD. But most of the diaphragm repair, we go from the abdomen, so you are not supposed to do the this thing. Breast cancer classification, yes, that could be one topic. The TNM classification and the proper classification, that can be covered. Yes. Okay, so like most of the people, they are saying urology. So maybe next class I'll take on prostate, focusing two diseases, maybe BPH and the prostate cancer. So let's see when is the next class, and this prostate topic I will take. Okay, so thank you very much, and all are fabulous. I can see in the chat box that you're answering most of the things absolutely fine, correct, and this gives very a good feeling that your students are studying, they are understanding the things, and they are applying the things. And I'll be more than happy when you become the surgeon and you are doing this, the real patients, the real scenario. Okay, thank you very much. Good luck for your exam, and God bless you all, and we'll meet again in this session taking one of another important